Good evening, Dr. Klein again from Raleigh, and bringing you news from the researchers and writers at the National Pain Council. Before we get started, remember to subscribe down below, and if you want to contact us, it's National Pain Council, CIL Council, all one word, at gmail.com. And you can send suggestions. This is participatory. We like to hear suggestions like, oh, that sounds stupid. Oh, you need to look this up. We like to have questions. That helps us to understand what people need to know. So a question might be, is it safe for me to take benzodiazepines and opiates together? And the answer is yes. It's perfectly okay. There's a lot of hysteria about that, but it's kind of like the witch trial hysteria, you know. Women that gathered together in town were considered witches. If women went through the door of the church, there were two doors, one for men, one for women, and banged the door, witches. So you see, once it gets around and everybody starts to believe it, the problem is no matter how many times you repeat a lie, you cannot make it truth. It just doesn't work. So we have talked about PROP before, P-R-O-P, which is an abbreviation for the Physicians for Responsible Opioid Prescribing. They are major and national spokesmen for avoiding opiate pain medicines. We disagree with that at the National Pain Council because we've heard from a lot of people whose lives were wrecked when they stopped taking these medicines. Who are these people? Chronic pain patients. Who are chronic pain patients? These are patients with prolonged body systemic inflammatory diseases. That includes autoimmune diseases. Both autoimmune diseases and our new category of rare painful diseases both have joint pain. Better than 90% of people as a complaint. That's a tip-off that you're in one of these anti-inflammatory diseases. But I want to show you an example of a prominent member of the PROP group. His name is Mark Sullivan. I believe he's a psychiatrist, like a lot of the people in the group. And he just wrote in July a paper that said that patients on long-term opioids are often irrational. Now, in my experience, and in the experience of our consulting physicians who have more than 200 years of practicing pain relief in patients, nobody has ever seen anybody that's irrational. It seems that Dr. Sullivan is mixing that up with the stimulant addictions, cocaine, methamphetamine, and even Adderall. These things take your mind away. They turn you into a psychotic person who stays up for a week at a time, doesn't eat, and wrecks their body with high blood pressure. That's not what's going on with heroin addiction. Heroin addiction basically has little crime. That's lots and lots of stealing, but no serious crime. The people who take high-dose stimulants are totally irrational, but Dr. Sullivan doesn't seem to know the difference. It's surprising because he's a psychiatrist. Let's just find some things he said. Long-term opioid therapy, that's opioid pain medicine therapy. Opioid is not just some, vague thing. It comes from the poppy plant. These are not the opium poppy. They used to take the seeds from the poppy 5,000 years ago and throw them in people's mouth, and they could dose them by the number of seeds, and they would get instant relief because the opium leached out of the seeds. Anyway, Sullivan is writing, long-term opioid therapy induces a state of opioid dependence. We've talked about that before. Remember, it's physical dependence or biochemical dependence that occurs in everybody who takes a pain medicine, everybody who takes a benzodiazepine, everybody who takes an antidepressant, everybody who takes an anticonvulsant, everybody who takes an antipsychotic drug, and even diuretics all become biochemically, interactively dependent. Terrible word, dependent. What it means is if you stop the drug, any of those drugs abruptly, you're going to have a physical withdrawal reaction. So long-term opioid therapy induces a state of opioid dependence. Yeah, duh. That compromises patients' decisional capacity. Boy, that's not true. They've done studies to show that your cognition is not affected at all. And ask any one of the 10 million people that take these and see what they say. Does it cause any problems with your decision making? It might if you were taking methamphetamine, but we're talking about opiate pain medicines here. Okay, and it specifically alters their perception of the value and necessity of the therapy. And so you don't know what's going on with your therapy. So he goes on to say that it should be taken out of the hands. The decision should be taken out of the hands of the patient. There's this big thing going on now. They even use an abbreviation for it. Shared decision making. SDM. Shared decision. You know what that is? You know what shared decision is? That's the doctor and the patient working together on this decision. So do patients make decisions totally without the doctor? Does the doctor make decisions totally without the patient? Yeah, that's what's happened. You're not getting any more benzodiazepines. You're not getting any more pain medicine. That's not the shared decision making, is it? As a matter of fact, that's kind of dictatorial, paternalistic, pain in the rear, professionalism. Since when do we tell patients what they cannot have or have? If you don't go out and get on a diet today, we're going to have you arrested. Just get out of my office. So he goes on to say, this Dr. Sullivan from Prop, who, by the way, has a long string of papers, which we at the National Pain Council, what we do is we go through all the papers and give them a rating. Dr. Sullivan's papers all get a rating of 10 bias points, which is the maximum you can get. He's biased to people not getting pain medicines. Okay, so now you take these medicines, you become dependent, it alters your perception of the value and necessity of therapy. Patients can often see no possibility of a satisfying life without a significant and immediate reduction in their pain. Wow. Does this guy read books? So what happens, you see, is people who take opiates for their rare painful diseases have dramatic improvements. They even have improvements with their allodynia, with their depression, with their brain fog, their blood pressure drops. So he's got this backwards. But yet, here he is, getting in the news, quoted. A more structured decision making that includes the patient's family and friends. What? So you're in for a sore throat. Let's get your grandparents in here. We're not going to decide anything about your sore throat without getting your grandparents in here and several of my doctor friends. They use motivational interviewing. That's really something. We have a great video I'll share with you at some time about motivational. What it is, it's some kind of Stasi technique to convince you to do what you don't want to do, but the interviewer wants you to do. It's really awful. It's psychological warfare. You remember that from a while back? Motivational interviewing. So Dr. Sullivan, and these are in his own words, you know, I'm just telling you what he said, and you need to the therapy that is desired by the physician needs to occur even if the patient objects. That's called forced medical treatment. We don't do that. in this country. So, Dr. Sullivan, if you wish, you can email us at National Pain Council at Gmail, National Pain Council, all one word, at Gmail, and respond to our comments. Thank you, and good night.